Good afternoon, everyone, and welcome to the Lewis Calder Memorial Library's 14th Biennial Ralph H. and Ruth F. Gross Endowed Lecture and Reception. Here to introduce today's distinguished speaker is Miller School of Medicine Dean Edward Abraham. Dr. Abraham came to Miami this summer as Dean and Chief Academic Officer of the Miller School of Medicine. He was most recently Dean of the Wake Forest School of Medicine in Winston-Salem, North Carolina. Dean Abraham is an internationally renowned pulmonary medicine and critical care physician and an accomplished scientist who has received extensive NIH funding for more than 25 years. He recently assumed leadership of the entire University of Miami health system when he was named Acting Executive Vice President for Health Affairs and CEO of UHealth. I am delighted to welcome him this afternoon. Dean Abraham.
Oh, I'm a little intimidated by all these microphones. Thanks very much, Joanne. Good afternoon to everybody who's here. I'm absolutely delighted to be with all of you today. I want to start by thanking the staff of the Lewis Calder Memorial Library for hosting this fantastic event. And I'd also like to welcome two special guests, Carol Gross-Clarkson and Patricia Gross-Bergman, who are Ruth and Ralph Gross's daughters. It's a privilege to honor your parents' memory with this ongoing lecture series. I'd also like to recognize the University and Miller School leadership, faculty, and staff who are joining us today. We're very happy that you're all here. The Biennial Ralph H. and Ruth F. Gross Lecture Series is a unique opportunity to listen to exceptional speakers who address topics that highlight the value of health information. I'd like to share a little bit about how this lecture series came to be. It's a wonderful history of how we have this lecture series. Ruth and Ralph Gross came to Broward County before World War II and purchased a poultry farm. The business had an inauspicious start. Only 8 of the first 100 chicks survived. At least there were the 8 of them. And instead of focusing on the chicks that died, Ralph Gross concentrated on why the survivors lived. So scientific method, inquiry, and action. He spent hour after hour in the Lewis Calder Memorial Library researching nutrition and consulting with faculty members here at UM. The feed supplements he would go on to invent saved his business and earned him a patent. After Mr. Gross passed away, his wife, Ruth, created an endowment fund to support the Calder Memorial Library, and then this fund supports this lecture series every year. We're incredibly grateful for that support. It's now my great pleasure to introduce our lecturer today, the president of the University of Miami, Julio Frenk. A noted leader in global health, President Frenk was formerly the Minister of Health in Mexico. He was also the Dean of the faculty at the Harvard T.H. Chan School of Public Health. He's a renowned scholar and a professor of public health sciences here at the Miller School of Medicine, so he's one of our faculty members as well. Please welcome President Frenk.
Thank you, Dean Abraham, and good afternoon to everyone. Thank you, Joanne. Thank you to all the staff of the Lewis Calder Memorial Library. I'm really honored to deliver this 14th Biennial Ralph and Ruth Gross Endowed Lecture. The list of previous persons who've delivered this lecture is very impressive, and it includes several, if not most, of my predecessors. As Dr. Dean Abraham shared, there's been a long-time relationship between the Gross family and the Miller School of Medicine and the Calder Library, and this is a wonderful example of creating a lasting legacy through endowment. Carl and Patricia, I just had the great privilege of meeting you, but I want to tell you that your parents' evident love of learning and their trust in the University of Miami continues to ensure that we remain excellent and relevant into the future. So I really thank you for that. I want to recognize a special guest, who is Dr. David Naylor, former president of the University of Toronto and former dean of the School of Medicine, who's one of our distinguished presidential scholars currently visiting the university, and I'm glad that he is going to be subject to the same torture as you are in the next few minutes. What I want to talk about is about global health in an era of retrenchment. Dean Gardner, when he kindly extended the invitation, he suggested a slightly different version of the topic, but he thought it would be interesting at this very critical moment when we're seeing a lot of reformulation of some of the basic tenets that have guided action on health at the global level. It would be interesting to reflect on what's the situation and what can we do moving forward. So what I'm going to do today, let me make sure, is to first try to analyze how health has transformed in a dramatic way, the changing context of health around the world. These are changes that occur day in and day out. They're not cataclysmic changes, so we tend to lose sight of them. But when you have enough distance to look, they are really huge changes that have been going on. And then as we enter the 21st century, there's been really a number of recent developments that are very, very important. I want to offer you a different way of thinking of global health, very different than the standard way we talk about global health, particularly in industrialized countries. Talk a little bit about the global health system and then illustrate the deep connection that the United States has to global health and why retrenchment from the global arena could be very dangerous, not just for the rest of the world, but I will make the case for the United States itself. So let me start by analyzing this changing context of health. We really are living in a new world health order that has a number of dimensions. The first one is the increasing importance of health in the global agenda. For decades, we thought that health was mostly what doctors and nurses and other health professionals have to concern themselves with. But the truth of the matter is that, especially since the beginning of the 21st century, health has become a growing topic in some of the central or most crucial items on the global agenda. Things like economic growth and development. Questions of security, of national and global security, which are highlighted every time we have a pandemic, but that are, a threat of bioterrorism, but that go way beyond. And issues regarding human rights. All of these, which are central issues in the global discussion, health became absolutely central as opposed to having been peripheral in the past. The second big trend has been accompanying that growing realization of the centrality of health, an expansion of funding, both in terms of international transfers from rich countries to poor countries for health purposes, what's called development assistance for health, which grew from 5.6 billion in 1990 to almost 40 billion by 2016, and that's just been an incredible growth. Now that is now been stagnant for, in fact, it stopped growing as quickly since 2011, more or less. But this has been an unprecedented growth, and no other area, by the way, has grown as fast as health transfers. Even more impressive are government expenditures in developing countries themselves, which are much, much larger than the transfers. So in developing countries, you can see this huge jump, almost more than quadrupling of government expenditures. This is by developing countries. So this is 18 times larger than what is transferred. A lot of times when we talk about global health, we're thinking about the money that rich countries invest in the health of poorer countries. It's actually much more what poor countries invest in their own health. And that's part of the realization of the centrality, the first trend that I was talking about. As a consequence, if you look at the global health scene, it's become incredibly pluralistic. When I started working in global health, you really could count the World Health Organization, a few other UN agencies, but that was it. The World Bank started getting interested. And then something happened at the turn of the 20th to the 21st century, I think linked to this growing realization of the importance, that we had this explosion of new actors. People don't think about it, but as early as 15 years ago, it's only been 15 years ago since the Gates Foundation, which is now by far the largest funder of global health anywhere in the world, was created. You had a number of global health initiatives, so-called hybrid partnerships, like the Global Fund for AIDS, TB, and malaria. Again, a multi-billion-dollar operation that was only created in 2002. So for decades and decades, we were in a world where you just had the World Health Organization, maybe the World Bank in the 1990s, and then suddenly, in this short decade, the first decade of the 20th century, you get all of these other initiatives. Philanthropic organizations like the Gates Foundation, a number of global civil society organizations like Médecins Sans Frontières, Partners in Health. You got professional associations, which now all have a global representation. Of course, you have the transnational corporations, which are global actors, pharmaceutical company, other health-related companies. You have research funders like the NIH, increasingly involved in the global arena, and you have academic institutions. We are part of the global health ecosystem. And then all of this happened while the world was continuing on what's been an unprecedented health transition, a huge shift in the health conditions around the world. Let me give you a little bit of the background, because again, this is the kind of changes that are not cataclysmic, happen day in and day out. Then when you look backwards, you realize how big they were. This is what's happened to a very simplified view, a schematic view of life expectancy, which is our summary indicator of health around the world for all of humanity. So for most of human history, life expectancy was very low, around 24. This is a simplification because you had a low level, and then you had all these epidemic peaks, when the Black Death killed a third of the European populations, when the Europeans came in contact with the Amerindian populations, and in the case of the Aztec Empire, killed 90% of people were killed, most of them by infectious diseases, some early examples of involuntary microbiological warfare. So there were all these peaks, but it was kept at a very low level. We come to the beginning of the 20th century, and around 1900, it's still only 30 years of life expectancy at birth as a global average. And then something happened in the course of the 20th century that by actually the 1980s, this had more than doubled. And we started the 21st century at 65 as the global average. So in this century, the 20th century, we had a larger gain in life expectancy than in all the previously accumulated history of humankind. There's a big debate of what prompted this, and that would be a separate lecture. But this has been called the health revolution of the 20th century, the more than doubling of life expectancy. That was accompanied by 3 mega trends. And again, I'm not going to go into any depth because that would be a separate lecture. But we had a dramatic shift in the average age at death. So death was something that mostly happened to young children. Most deaths happen in children under 5. Today, a minority, a tiny minority of deaths happen among young children. And we're more and more living to the biological limits of human life. Secondly, the cause of death changed dramatically from external, mostly infectious diseases, to diseases that are linked to lifestyles and living conditions, and that have a huge behavioral component. And most importantly, the experience of disease changed. For most of human history, the experience of disease was a succession of acute episodes from which one either recovered, from which either died or recovered, and recovered only to get the next episode. Instead, disease now, most of us spend substantial parts of our lives in some level of disease or disability. And it's become a condition of living, very often stigmatized. And people say, in the way we talk, we say, I live with cancer, I live with AIDS, I live with diabetes. It is a condition of living, as I said, very often. It's in the case of AIDS or mental illness or cancer, highly stigmatized conditions. And so if we look at the world today, and this is this enormous change, this enormous, what's been called a health transition, an area where I was very active in my early academic years, what we see is a triple burden of disease around the world. In most of the developing countries, especially in sub-Saharan Africa, we still have a huge unfinished agenda of common infections, a maternal mortality, and undernutrition. At the same time, without having finished this, which has been the secular series of problems, still an unfinished agenda, we have the emerging challenges represented by non-communicable diseases like cancer, heart disease, diabetes, mental health issues. And then if you add on top of that, we have a number of health risks directly associated with globalization. Of course, the most clear examples are pandemics, which affect rich and poor countries alike, and the health consequences of climate change, like we're experiencing here in South Florida with the resurgence of vector-borne diseases as global warming changes the ecology of vectors like mosquitoes. So a very complex picture, an unprecedented health transition. In parallel, we had another huge change, which was the appearance of complex health systems. For most of human history, the social function of taking care of the sick and preventing disease was fulfilled by undifferentiated social institutions like the family or like religious institutions. But in the 20th century, there's a second health revolution, paralleling the first one, where we create these specialized and differentiated entities called health systems, which have grown now to be actually the largest sector of the largest economy in the world, which is the United States, at 18% of GDP, the largest sector of the economy, and one of the largest sectors of the global economy. It's about 10% of global GDP, and actually this is now closer to $7.5 trillion that are invested or spent. A lot of that is wasted, but most of it is well spent in health. This is the entire health industry. Now, one country alone, the United States, accounts for about 3 trillion. Okay, this is how much we spend. This is a 20th century phenomenon. In fact, we're here in a hospital. It's not until the 20th century where hospitals are thought of as places where you actually go to get cured. For most of history, hospitals were places where you went to die, especially if you were destitute, like if you were homeless, you went to the hospital to die. It's the idea of a therapeutic hospital, although it started earlier, around the 18th century, it really is a 20th century concoction. And we don't think like that because it's so much part of our daily experience, but that's that kind of a revolution. And it's reflected this explosive growth of what we call now specialized differentiated sector. It employs millions of people, including probably most of all in this room, not all of us, but most of us in this room. There are about 8.5 million doctors, 18 million nurses, and millions of other health professionals. And it's become a ubiquitous presence in our lives. Today, in our world of more than 7 billion people, the vast majority of people are born in the contact with the health system, will die in the health system, and will spend substantial amounts of time in a health system. That's a new phenomenon. So these changes on the global sphere that I was talking about happen as these two revolutions in the changing in health conditions and in the expansion of health systems continue to unfold in the 21st century. So we have had what I would call the 21st century roller coaster in global health. And it starts right, in the year 2000, although that really was the last year of the 20th century, not the first of the 21st. But in the year 2000, all countries in the world adopted something called the Millennium Declaration. And for the first time in human history, every country, rich and poor, every one of the countries of the world agreed to a number of shared goals called the Millennium Development Goals. Truly an unprecedented level of coordination and accountability. Everyone held themselves to accountability. 8 goals that everyone would pursue. 3 of those were directly related to health. Reducing infant mortality, or infant mortality, reducing maternal mortality, and dealing with the big infectious diseases like AIDS, TB, and malaria. There was another one having to do with hunger and undernutrition. There were others that had a lot to do with health as well, like gender equity, poverty. But 3.5, let's say, were directly related, almost half of the MDGs. That just shows how central health was. Then we get 2001, and we get 9/11. Just this is all, in the very beginning of the 20th century, 21st century. And if you remember, after the attacks on the Twin Towers, the same year of 2001, we had the anthrax attack. And that again brought home, literally, the idea of threats to health security and a lot of concern about bioterrorism. We then, partly reflecting these trends, went into this huge expansion in development assistance for health that I illustrated before. That more or less plateaued around 2008 and 2010. It was still growing at a smaller rate, and now it's been basically flat. And probably, given trends in the world, it's going to start declining very soon. Then in 2009, we get first the H1N1 pandemic of influenza, a novel strain of influenza virus. We then got this rapid succession of pandemics that increased the public awareness about these global health threats, like Ebola, which got a lot of visibility, Zika, chikungunya, dengue, all of these diseases that have now a lot of exposure in the media, again increasing concerns about health security. And as we're in the middle of these trends where health seems to be on the rise, as of last year, we start seeing a trend, especially, obviously a lot of those trends were brewing before, but sort of the start signal is the result of the Brexit referendum in the United Kingdom. A clear signal of the rise of nationalism, populism, and a discourse that speaks about retrenchment from the global sphere. Whether, we hear here America first, but you can go to some of the candidates that lost the election in France, and it was France first. And if you go to Russia, you will hear Russia first. And, the Brits decided that they were no longer Europeans, they were British, so they would exit the European Union. And it's a general discourse about retrenching from global engagement. So what I want to argue is that that's not a good idea. But for that, because, and let me just give you the key message, because we need to continue to pay attention to global health. And this was articulated, and I'm talking now of the United States paying attention to global health. Already back in 1997, the Institute of Medicine, which is now the National Academy of Medicine, published a report called America's Interest in Vital, actually this is a typo, it's Vital Interest in Global Health. Vital Interest in Global Health. I was a member of this commission, and so I know the report well. And it basically argued and demonstrated with good evidence that there were all of these reasons why the United States has a vital interest in global health. First of all, it protects the people of the United States because, as we will see, in an era of interdependence, the health of the people of any country depends on what happens in other parts of the world. Secondly, it enhances the US economy. The United States is the leading participant in that 10% of the global economy devoted to healthcare, whether it's through the pharmaceutical companies, the equipment companies, the electronic companies that have medical applications. So it's actually a huge sector of the American economy, the largest sector of the American economy, and a lot of that is globally, is formed by global companies. Third, it advances US international interests in particular, and it leads to what's been called smart diplomacy. And one example you will see is PEPFAR. The extraordinary PEPFAR stands for the President's Emergency Program for AIDS Relief in Africa. Probably the single most important legacy of President Bush, the second President Bush legacy, the most important part of his legacy, that greatly enhanced the standing and prestige of the United States in Africa in particular, but around the world. So what's been called smart diplomacy is a lot of that articulated through health actions. Now, if we're going to argue that we need continued attention to global health, we have to first understand what are we talking about. And that's what I want to go to the second part of my presentation. So I want to propose a new way of thinking about global health, particularly in developed countries and in many academic institutions. We tend to think of global health as foreign health. Global health is whatever is happening outside, and we contrast global with domestic. So, you know, a faculty member is seeing patients here, but then they go to Haiti, and that is global health. It's whatever happens outside, it's foreign health. Well, I want to argue that global health is not foreign health. One of the reasons is the last time I look at the map, the United States was very much part of the map of the globe. So global health includes what happens in the United States. The traditional view of global health has been very simple paradigm. Risks, these are dreaded bacteria, maybe a microbiologist in the audience can tell us what it is. Risks, like microbes, flow from south to north. And solutions flow from north to south. That was the paradigm in dominating global health thinking, particularly when we spoke of international health. Instead, I would like to suggest that the essence, the current view of global health, is that the essence is about interdependence. It's not about protecting ourselves from the risks that migrants are going to bring, all those diseases that they will bring, and how do we protect ourselves and make investments so that, you know, they are not so sick when they move here or they don't move at all. It's not about that. It's about the concept of interdependence. Interdependence means that no country in the world, not even the richest and most powerful country, can by itself control all the threats associated with health by itself, but that it needs to engage with the others. And the reason is that a lot of what happens in any one country in the world is determined by events that are occurring somewhere else. A good example of that I will show in a minute. But just keep this in mind. It's the idea of interdependence. So global health is really the study and action around interdependence as it affects health phenomena. And I like always to think in very parsimonious ways that when you think of the health of populations, there's two main dimensions that you need to analyze. On the one hand, the health conditions of people, the distribution of risks and diseases in a population. On the other, the organized social response, which is structured through the health system. So every time we think about the health of a population, we need to see what's the profile of diseases, and then how is the health system organized as a response to those conditions. But you can do that analysis either at the national or at the global level. And at the national level, if you study the health conditions, that's the national epidemiologic profile. And if you look at the organized social response, this is what national health systems articulate. At the global level, because of interdependence, the dominant topic around health conditions refers to the global transfer of health risks. And then there is something that we can think of as a global health system. And this is what we need to understand. So global health is not about foreign health. It's about understanding the global transfer of health risks and the global health system. What are some of those risks? And again, I'm closing over a lot of things that could themselves be lectures. By the way, all of this has been published in a paper that appeared in the January 2013 issue of the New England Journal of Medicine. It's called Governance Challenges in Global Health. And another one that appeared exactly a year later in January of 2014 in The Lancet, which has some long title that I don't remember, but all of these ideas are taken from that for anyone who wants further reading. So what are the global transfers of health risks? First, global environmental health threat, sorry. I already mentioned climate change as an example. You know, you can do whatever, but every time there's pollution in Beijing and the winds are blowing in the wrong way, actually certainly Hawaii and other parts of the United States in the Pacific are affected. When we have CO2 emissions that lead to global warming, some of them are originating in one part of the world. You can't deal with those if you do not engage globally. So that's the first one. I think climate change now has brought it. But even what appear to be local environmental threats, like the example I gave of air pollution, can travel around the world. Second, of course, the movement of people. Not just migrants, but tourists, people who are every day, there's millions of people moving around, and with people, they move, you also move microbes and other threats. But it's not just people and microbes that move, it's also lifestyles. So one of the forms in which we transfer risks is by the adoption of risky lifestyles. So, every time a multinational producer of junk food in the United States, I won't say names, opens shop somewhere else, we're transferring risks, the risks of bad nutritional habits. Smoking is a great example of that adoption of risky lifestyle. But that, by the way, accounts for a large part of the huge expansion of obesity around the world, so much so that people now speak of globesity as truly a global pandemic. Then you have variance in health standards, particularly I'm talking here about occupational and environmental health standards. Every time a factory moves from a country with high regulatory standards in terms of environmental or occupational health to another where those standards are lower, what you're doing is you're transferring those risks. Of course, there's a whole export of toxic waste around the world. Those are examples of the transfer. The trade in harmful products, whether they are legal, like tobacco, or illegal, like other drugs. And then the spread of medical technologies, and a great example here is the spread of antimicrobial resistance, okay? So you can have the best regulations on the prescription of antibiotics in country A, but if country B, a neighboring country, doesn't have those restrictions and people abuse the use of antibiotics and create antimicrobial resistance, those microbes don't carry passports. There are no walls that stop them, believe me. And they will affect the first country that had the perfect regulations. So the spread of antimicrobial resistance and other forms or secondary effects of technologies is another way. As you can see, that old paradigms that risks move from south to north is no longer true. Risks move from south to north, from north to south, from east to west, and from west to east. This is the reality of interdependence. Let me look at the other side, the global health system. I already spoke about one of the big trends, which is the global health, the growing plurality in the global health system, and I'm not going to spend a lot of time. We now have, the WHO, but we have all this cast of other actors in the global health scene. And then you have other areas of global governance that have huge impact on health. What we need to understand is that there is a system, it's not as clear as national health system, it's a little bit more diffuse because we don't have a global government, so it's not like there is a global department of health, right, that you could identify. But there are essential functions that are carried out in this global health system. And I'm, again, just going to quickly enlist them. There are 4 big functions that are carried out. One is the production of global public goods. I will talk in a minute about that. Management of externalities across countries, actions in one country that affect another. The mobilization of global solidarity, and then a function of stewardship. Let me quickly tell you what each of those mean. There are these global public goods, mostly knowledge-related, goods that benefit everyone around the world. Research is the quintessential global public good. Research doesn't matter where it happens, it will benefit other people. It's a global public good. But also standards and guidelines. Some of them are used for national use. For example, most people don't know this because we grow accustomed to these things. But in this world, with so many differences, with so many cultural differences, so many different cultural interpretations, it's nothing short of a miracle that there is something called the International Classification of Disease. And every single country in the world classifies diseases the same way. This is part of what the World Health Organization does. It's not very glamorous. There's no global fund for the International Classification of Disease. But nothing in the US or anywhere else in the health system would work if we didn't have a standard way of classifying diseases. It's a global public good. It's standards and guidelines. Standards about what do you need to produce a vaccine and trade a vaccine internationally. So a lot of them are to regulate international transactions. Those apply to everyone, and they make for a more orderly national health systems, but these are carried globally. And then comparative evidence and analysis. Even now, with all the debate around Obamacare, people keep bringing, well, what about the Swiss model? What about the Canadian model? Dr. Naylor just gave a brilliant lecture on why Canada is not a good model. But that kind of comparative analysis and evidence of what works where is a big part of those global public goods. The second big function, which is one we've now become very aware because of all the pandemics that we've been dealing with, is what are called externalities, and particularly surveillance and information sharing. Again, no one really sees this, but there's a whole network of laboratories around the entire world that are monitoring what strains of virus of influenza are circulating, and that produces the mix that will determine what vaccine is produced every year. It's done for the northern hemisphere and for the southern hemisphere. We don't see this, but it's a level of coordination and cooperation, and we would not have influenza vaccines that are effective in any country of the world if we weren't doing that kind of coordinated action. And then when we do have a problem like Ebola, or like influenza, or like SARS, then coordinating, you require a global response, because these are by definition problems that affect the entire world. There is the mobilization of global solidarity, helping the poor parts of the planet. That's the one we tend to think most of when we talk about global health, and that's what development assistance for health does. Whether it's development financing, technical cooperation, humanitarian assistance. By the way, we often do humanitarian assistance even for rich countries when there's a disaster, like in Japan with the earthquake and tsunami. There was a lot of global solidarity towards Japan. And even more recently for the hurricanes here, the United States was receiving offers of help from other parts of the world. And then this concept, which means helping people where the problem is not an acute emergency, but people who live in countries where the government is the main perpetrator of violations to their basic rights, and we, the global community actually helps people in those countries. It's a long-standing tradition of what's called global solidarity. And finally, there's a function called stewardship, which has to do with convening for negotiation, consensus building, a lot of rule setting that makes it possible, for example, to trade drugs while respecting patents, and evaluation for mutual accountability. I was involved in doing a ranking of health systems at the World Health Organization. We evaluated every country in the world, including the United States, and advocating for health in other sectors. So those are the functions that happen there. And I'm going to skip this last one. And I want to go to the final part, which is about the US. And I just want to finish by giving two very specific examples that illustrate what are the risks of retrenchment. One is about the FDA and global health. I spoke of the global transfer of health risks. And again, it's important that people who live in the United States realize that FDA-regulated products come from more than 150 countries, because we are in an interdependent world. That about 25% of all food available here, purchased here, comes from outside, and about 25% of medicines, okay? So when we talk about FDA, it's a national agency, a domestic agency, but it's very active if its mandate is to protect the health of the American public, because we live in an interdependent world. Along with the global transfer of health risks, there's also the global transfer of health opportunities. So the FDA, at least while Margaret Hamburg was the commissioner, was very active in, working international cooperation with other countries. And they were designing minimum global standards for safe food, drugs, and other medicine. A lot of exchange of expertise, evidence-based regulation, so that we don't have too burdensome regulation, but we have enough that protects the public. And they were very active because, again, if some of the countries with which the United States does a lot of trade could harmonize some of their standards, you would have a better system that protects the health of everyone. So you can also transfer opportunities. And then my last example is, of course, topic of great currency, which is Obamacare, or the Affordable Care Act. Again, if, when this was passed back in 2009, I guess, everyone thought, well, this is a typical example of a domestic health issue, right? It's health legislation in a particular country. But is the ACA domestic or global? Well, of course it's mostly domestic, because that's a false dilemma. Everything is now domestic and global, or as someone said, everything is global and local. It rearranges access to health in the United States and insures a lot of people and arranges the way providers are paid, etc. But it has major effects on the international demand for health workers. If suddenly you have a legislation that's going to provide insurance for 40 million previously uninsured people, and you can expand access to care, there is the labor market for health workers is truly global, as attested by several of us who are in this room today, okay, who could train somewhere, and I'll show you a couple of numbers in a minute. Secondly, this is a great opportunity for sharing evidence from actually other reforms of implementation. And when the debate was going on, again, people were calling about evidence of what worked in other places. Similarly, as the Affordable Care Act is being implemented, it's gotten a lot of very valuable lessons for other countries. Like, for example, how not to set a website for enrolling people. It is a huge opportunity for frugal innovation. I will say a word about that in a minute. And it is an opportunity for increasing modes of global delivery of services like telemedicine. And let me just give you a couple of examples. The first piece about effects on the global labor market. These are some of the numbers about the proportion of workers in the United States that are trained or that are immigrants. And I will just point to you to the fact that a little bit over a quarter of all physicians practicing in the United States were actually trained abroad. So we have very, very highly integrated global labor market for doctors. Nurses is a huge part. The proportion there is a little bit lower of registered nurses. It's about 16%, but it's still a huge part of the total labor force. So you see that almost in every category, you have very significant proportions, the highest being among physicians. The second point I made, frugal innovation. Frugal innovation was a term coined particularly for innovations that happened. It started in India, a very innovative country, and that then could be imported by high-income countries to improve their own performance. And here are some examples, some biomedical technologies. The production function of health services. People talk about task shifting, being able to do the same task with health providers that cost much less. That started mostly in developing countries, and we now are adopting that for integrated practices with licensed physician extenders, licensed nurse practitioners, etc. The idea of shifting and working as team actually was not originated here. It actually came from experiences from around the world. Some delivery platforms like mobile health, mobile platforms, and different incentives for users and providers that have been tried in other parts of the world. These are all examples of frugal innovation that arise in resource-constrained settings and there benefit richer countries. And then the last example of what I'm talking about, which I would call Patients Without Borders. We have a very noble organization called Doctors Without Borders, Médecins Sans Frontières, but this is Patients Without Borders. Because there's about 40 million people a year that cross a border to receive health care. A lot of them come here, but a lot of them are Americans who go there. Some people refer to this as medical tourism. I do not like that term because it kind of trivializes the whole concept. It looks like people are just going for fun tourism. But it is a major phenomenon, 40 million people, something like 45 to 72 billion dollars of business, of patients receiving care in a place other than their country. And about, this is a recent estimate, but it is an estimate, about 1.5 million Americans who travel outside. But these are Americans that actually travel, and I'll show you a slide of why they would do that. But in addition, there's a huge amount of Americans who reside outside and who receive care somewhere else, or sometimes may need to travel back here for certain procedures, but they will receive at least most of the routine care outside. But just talking about why is this the so-called medical tourism, this is why. I mean, look at some, the comparative costs of some particularly elective surgery procedures where the costs are, I think, speak for themselves. The fact of the matter is this is another example of the interdependence. We can't act within the borders. If, you know, I was Secretary of Health of Mexico, it was clear to me that if I needed to fulfill my constitutional duty, which was to protect the health of the people of Mexico, no one asked me to protect anybody's health, anybody else's health, but I was responsible. But I couldn't do that if I didn't engage globally. So to me, there was a seamless continuum of the global and the local. It was all local. So let me leave you with a phrase, one of my favorite quotes, which I think captures the essence of what I've tried to convey today. It's a beautiful, as most of his quotes, quote from Martin Luther King in this 1968, 50 years ago. He already had the presence of writing what you see there. It really boils down to this, that all life is interrelated. We are all caught in an inescapable network of mutuality, tied into a single garment of destiny. Whatever affects one directly affects all indirectly. This is why we cannot afford retrenchment. Thank you very much.